In pain medicine, the most important area is history taking. If a patient comes to a doctor with any kind of pain, the first part what a pain physician should do is to take a proper history for the evaluation to understand the reason behind the pain. In clinical medicines, whenever we are evaluating a patient suffering from any kind of problem, there are three important pillars. One is history, one is clinical examination, and another is different kinds of investigations like MRI, X-ray, blood test. Out of these three pillars, in pain medicine, the most important pillar is history taking. Let us take one example. Suppose somebody is suffering from migraine, some kind of headache. Patient is coming to a doctor with some kind of headache. So, maximum clue for diagnosing the migraine should be coming from the history itself. The clinical examinations, we are not going to get anything. The investigations, we are not going to get anything. So here, we should still do the clinical evaluations, clinical examinations, physical examinations. We should still do the MRI, CT scan to rule out the other possibilities, but the maximum clue will be coming from the history itself to make a diagnosis of migraine, to make a diagnosis of the cluster headache, to make a diagnosis of the tension type of headache. So, these are the classical examples. In the same way, there are lots of different types of pain where the diagnosis is based particularly on the history. So, the maximum emphasis should be given on history whenever we are evaluating a patient suffering from pain. So, today in this lecture, we are going to explain the different steps, the art of taking history in pain medicines. So, let us go ahead with the different steps. Let us start with the definition of pain. Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. What is the meaning of that? That means sometimes the patient feels that there is some tissue damage and that's why the patient is having pain. So, in these situations, we are not going to get any kind of clues apart from histories. So, emotional changes, we need to understand it from the history. So, in the definition itself, you can understand that whenever you are evaluating the patient suffering from pain, the most important area where we should give the maximum emphasis is history. So, what are the areas? So, important points whenever you are taking the history. One is, we should give the sufficient time. We should not be in hurry. We must be giving sufficient time whenever we are taking the history. Typically, whenever you are evaluating a patient first time, the time should be at least half an hour, if not 1 hour. So, half an hour to 1 hour time is needed for the proper history taking in pain. Next is very careful listening. So, listening itself is very, very important. Don't interfere much, except if the patient is going towards some irrelevant talk. Otherwise, you just listen carefully. Another thing you remember, whenever you are listening, the patients complain very nicely with patience, it itself relieves the pain. Psychologically, the patient feels better that he could explain his problem properly to the doctor. So, this talking, whenever you are listening very carefully, itself reduces the patient's pain. Then is empathy. And here, we must be remembering the difference between the sympathy and empathy. So, we must not show any sympathy, but we must be showing the empathy to the patient. We must be empathetic. Trust development. Our behavior, our talk with the patient should be such that there is a good trust built between the patient and the doctor. Patient-doctor relationship is very important. Unless the patient is trusting you, he is not going to tell everything about his or her problem very nicely. Should we intervene? And when and how to intervene? Again, don't interfere much. Don't talk much. Most important part is listening. But sometimes, if you feel that the talk or what the patient is telling is not that relevant, you may interfere. But try to interfere as minimal as possible. Be a very good listener when you are taking the history. And sometimes you might be giving some leading question as well if he is going to the different track. particularly the areas, what is important for you. Say for example, if you are taking a history of patient suffering from the migraine, you must be telling, if the patient is not complaining, you must be telling, do you feel pain more when your meal is skipped? Or when you are going to a bright sunlight, do you feel more pain? So this kind of leading question sometimes is needed, but most important part again and again we are emphasizing is the careful listening. Then is your effect of pain. So many times because of the effect of the pain, patient is having the different ways of problem. Sometimes patient is psychologically upset. So you have to understand those areas that this incoherent speech or these emotional changes might be because of the effect of the pain. And special attention, particularly many patients when they are describing their sufferings, so they might be emotionally absent. Many times they start crying. So the special attention is needed. Sometimes in some patients cannot talk much, difficulty in showing the different kinds of expressions. So in these situations, you might be showing that special attention to these patients. So remember all these points: sufficient time, careful listening, be empathetic, not sympathy, the trust development, don't interfere much except certain conditions, remember the effects of the pain, and sometimes you need to give special attention to the patient's complaint. Next, what are the steps? So those are the backgrounds, means what to keep in our mind when we are taking history. But these are the different steps. The most important part is your chief complaint. Chief complaint, we have to remember that it should be only 2 or 3, not much. Then history of present illness. This is the most important part, and here we are having the 10 points. I'll be coming to these 10 points later on. Just before that, let us see what are the steps. Chief complaint, then history of present illness. This is the most important part, again you are telling again and again. Then what is the treatment history or medical history, the family history, occupational history, personal history, and psychological history or psychological assessment. So we'll be going to that points in details later on. But what is most important is history of present illness. So in the history of present illness, there are 10 points. There is some mnemonics. I'll be coming to that mnemonics first. So what is that mnemonics? Quick questions make diagnosis pretty simple. Think really about them. Quick questions make diagnosis pretty simple. Think really about them. So quick question. Quick is your quantity or severity. Questions is your quality or nature of the pain. So here again, the quantity or severity of the pain can be divided broadly into 2: unidimensional and multidimensional. We'll be discussing these points later on in detail. Then quality or the nature of the pain, whether the pain is neuropathic, whether the pain is nociceptive. With the history itself, we can have some important clues. The bedside tools based on the history can tell us whether the patient is suffering from the neuropathic pain, nociceptive pain, or mixed kind of pain. Then quick questions make mode of onset and location. So how it started and where. Diagnosis is your duration and frequency. How long the patient is suffering, since last 3 months or 2 months, or what is the frequency, whether it is continuous, whether it is coming in the episodes, whether the some part of the day is having the pain. Pretty is posture and its relation to the pain. Whether sitting is aggravating the pain, whether sitting is relieving the pain, whether walking is making any difference. Any special character of the pain, like sometimes pain is burning, sometimes tingling sensations. Timing of the pain, at what time pain is coming, is it coming in the morning or is it coming in the evening? Then your radiation of the pain, whether the pain is radiating down to the leg, radiating down to the hand. Aggravating and relieving factor, which factors aggravates, which factor relieves the pain, and other tied up symptoms or related symptoms. That means whether along with the pain, the patient is having some numbness, motor weakness, tingling sensations. So what other associated symptoms are there, that is also very important in making a diagnosis. So let me go back to this, that these are the different steps of history of present illness, and we are going to remember it. Quick questions make diagnosis, pretty simple. Really think about them. So quick is your, first quick is your quantity. It is unidimensional, multidimensional. Then second questions is your quality. Then is your quick questions make, mode of onset, diagnosis is duration, pretty is posture, simple is special character, think is timing of the pain, really is radiation, about is aggravating factors, them is your the tied up symptoms. So just remember this mnemonics: quick questions, make, diagnosis, pretty, simple, think really about them. So these are the 10 points, and now we will be elaborating each points in detail. So first is your the chief complaint. So we are talking about whole of this history, chief complaint. Then we will be coming to the history of present illness. In the history of present illness, we will be elaborating the all 10 points, and then we will be coming to the medical history, family history, personal history, occupational history. We will be coming step by step. First is chief complaint. So what is important here? When we will be writing the chief complaint, we will be writing the locations and duration. This is very important. Like somebody is suffering from the shoulder pain for the last 3 months. So location is shoulder and duration is last 3 months. And 2 or other complaints should be 1 or 2 complaints, not 5, 6 complaints, maximum 3 complaints in the chief complaints. Other complaints should be coming in the tied up or associated symptoms, last point in the history of present illness. So this is about chief complaint. Next is your the how we are going to assess the quantity of pain. Quick questions. First is quick. Quick means the quantity, and that can be assessed by unidimensional pain scale or multidimensional pain scale. So here I will be elaborating a little bit about what is unidimensional, what is multidimensional. We have seen in the definition of pain by IASP that pain is an unpleasant sensory and emotional experience. So what is the meaning of that? That means pain not only hurts us physically, pain also hurts us emotionally. It is there itself in the definition. But apart from that, pain also deranges our cognitive factors. So pain is not just hurting us physically, you have to remember that. And when we are assessing the amount of the pain which is hurting physically, we call it unidimensional pain scale. But if you can assess how much it is hurting us emotionally, if you can assess how much our cognitive functions is deranged or the other aspects affected by the pain, then that tool is your multidimensional pain scale tool. So there are several unidimensional. Unidimensional is a little simple, quick. Multidimensional, it takes little time. So we'll be discussing about both the unidimensional as well as the multidimensional pain scales. So unidimensional pain scales. There are lots of unidimensional pain scale. Assessment of the severity or intensity of the pain, the unidimensional. What are the things? One is verbal rating scales, VRS. So what then we are doing it, we will be coming to this in detail. In the verbal rating scale, we are just asking whether the pain is mild, moderate, severe, excruciating. We are just asking how is the pain, is it mild, is it moderate, something like that. Then the binary scale, it's just telling pain is there, yes, or pain is there, not there, no. So it's binary scale. Then it's numeric rating scale. Numeric rating scale is from 0 to 10, we have to assess. Facious rating scale, so you have to understand the amount of the pain or intensity of the pain looking at the facial changes. And visual analog scale, so we are giving a scale and we are assessing it how much. So we will be going in some of this in details. One of them is NRS. In the NRS, what we are doing? We are asking the patient that if 0 is equal to no pain and 10 is the maximum pain one can imagine, then no pain is equal to 0 and 10 is equal to maximum pain, and in between what is the pain. And normally, conventionally, the mild pain means up to the 3 is your mild pain, 4, 5, 6 is your moderate pain. This is your verbal rating scale. And severe pain is your 7, 8, excruciating pain is your 9, 10. So this is the relation between the verbal rating scale and the numeric rating scale. Then this is your Wong-Baker faces pain rating scale. So here there is, the different pictures. So happy, no pain, then hurts a little bit, then hurts little more, then, here it was like this, here it was like this. So hurts worst. So these are particularly important in the neonates who can't speak, in other people who can't speak, or in comatose patient, unconscious patient. So these are the areas where we have to understand the amount of the pain looking at the patient's face. So this is your Wong-Baker face pain rating scale. Then your visual analog scale. So here what we are doing, we are giving a scale and we are asking, please mark where is your pain. Is it here? Is it here? Is it here? And see what is the amount of the pain. So this is in short about the different kinds of unidimensional pain scale, verbal rating scale. Then your verbal rating scale is no pain, mild pain, moderate pain, severe pain. So visual analog scale, you put the mark there and understand, give a scale and understand. Numeric rating scale is 0 to 10. You tell them, explain them. Here the scale is not important. Here you are telling them how to assess it based on the number. 0 is equal to no pain and maximum pain is your 10. And then last is your facious rating scale, Wong-Baker's facious ratings, where we are understanding the pain, amount of the pain based on the facial expression. So these all are unidimensional pain scale. And what is the limitations of the unidimensional pain scale? That it is assessing only the physical aspect of the pain. How much pain is hurting us physically, that is being assessed by the unidimensional pain scale. Now the multidimensional, as I already mentioned, it is assessing the other aspect of the pain. How much it is hurting us emotionally, how sad we are, or how much it is affecting our other cognitive functions, whether I am unable to do my normal household work, whether I am unable to read, whether I am unable to concentrate on any work which needs some concentrations. So all this can be assessed by the multidimensional pain scale. So the multidimensional pain scale, the most popular is your McGill's pain questionnaire. It is little bit of little more elaborate. It takes some time, but that is the best which can assess the different aspects of the pain. This is little short, brief pain inventory. Sometimes this is also being used, and these are the others which is more relevant to the research purpose, not for the daily clinical practice. As a whole, the multidimensional pain scale is not being used routinely in the clinical practice because it is very elaborate, and in a busy clinic, it is very difficult to go all ahead with that. So now first comes the McGill's pain questionnaire. So McGill pain questionnaire, it is, you see, there are 10 sets of questions which is assessing the 1 to 10. So these all questions are for the physical aspect of the pain. You see some of the example: 1, flickering, pulsing, throbbing, pounding, jumping, flashing, shooting. So if the patient is telling any one of them, you put and take the number, how many of them, and you put there maybe 4 or 5 or 6, something, whatever it is. Then there are 5 sets that describes the motivational, affective, reticular and limbic functions. First part was nociceptive areas. Second part is the limbic areas, the emotional aspect. And that is being assessed by the 5 sets of questions. So these 5 sets of questions, this is assessing the emotional aspect: tiring, exhausting, suffocating, sickening, fearful. So these all are example of the assessment of the emotional areas. Then your one set that describes the cognitive evaluative cerebral cortex area, this one, cognitive areas. So annoying, troublesome, intense, miserable, unbearable, these are the questions. Then 4 sets of questions describes the miscellaneous dimensions. So there are few other miscellaneous areas which is also being affected by the pain. And then here you feel that is your PRI. PRI is the sensory aspect. This is your emotional aspect. this is your the cognitive aspect, and this is your miscellaneous aspect. And apart from that, that means and the total PRI you will be counting from 1 to 20, and there is also PPI. PPI means your how much, it's similar to that of the verbal rating scale, that you are giving no pain, 0, mild, discomforting, distressing. So here you will be putting 3 or 4 or something like that based on your what is your PPI. So this is the McGill's pain questionnaire, and apart from that, you should also mark the area. Suppose somebody is having the shoulder pain, somebody is having the knee pain. So you also mark on that particular area to understand that where is the patient's pain. So this is your McGill's pain questionnaire. As you can understand, there are lots of questions, and it takes some time to evaluate. But that is one of the best tool to evaluate, because it's not only assessing the patient's physical aspect of pain, it is also assessing the other aspect of the patient's pain. So we have discussed about the first Q, means the quantity of the pain. Remember the mnemonics? Quick questions makes the diagnosis pretty simple. Think really about them. So we have first part. Quick means the quantity of the pain. Now we are coming to the quality of the pain. Assessment of quality of the pain. That means whether the pain is your nociceptive, neuropathic. So we can assess by the different questionnaires, and these questionnaires, there is long list of questionnaires, and these are all known as the bedside neuropathic pain assessment tool. And with that, we can understand whether the pain is nociceptive, whether the pain is neuropathic, or whether the pain is mixed. Till now, the bedside tool for assessing the nociplastic pain is not there. You must be aware that nociplastic pain is a new kind of pain. It's a new classification by International Association of Study of Pain, where there is no tissue damage, neither non-neural tissue damage nor the neural tissue damage. So if the neural tissue damage is there, we call it neuropathic pain. If non-neural tissue damage causing pain, we call it nociceptive pain. And if there is no tissue damage of any of this kind of tissue, then you call it nociplastic pain. These are the 3 different types of pain as defined by IASP. So here, what we are going to describe now, to assess the quality or nature of the pain, is we are having the different kinds of neuropathic pain assessment tools. With that, we can understand whether the pain is nociceptive or neuropathic. So these are the different tools. One is Leeds assessment of neuropathic symptoms and signs. In short, LANS, LANSS. Then neuropathic pain questionnaire, NPQ. Then is your DN4. Then is your pain detect tool. Then is your ID pain. So I'll be just talking briefly about all those things. And in our hospital and most of the other pain clinic, this is pain detect tool is one of the important tool which has been used by lots of pain clinic around the world. So we also in our clinic, we are using that tool. So this is your LANS, Leeds assessment of neuropathic symptoms and signs, LANS. So here there are 5 symptoms, 2 signs. So what are these 5 symptoms and 2 signs? The pricking, tingling, pins and needle sensations, electric shock-like, skin color changes, the pain evoked by the light touched, the skin temperature, whether it is a hot or burning, signs, brass allodynia, raised pin prick threshold, and each carries different numbers. Some carries 5 numbers, some carries 2 numbers. So you have to remember that, or you must be having some form for that. Its sensitivity is 82 and specificity is your its sensitivity is 82 to 91% and specificity is 80 to 94%. It's quite good, but again you have to remember the score of the individual signs and symptoms. That is one of the important areas. If the score is below 12 out of 24, total score possible is 24, then it is unlikely to be neuropathic pain. That means it is nociceptive pain. If the score is more than 12, then this score is most likely to be the neuropathic pain. So this is LANS. You can follow any one of them. You need not follow all of them. Then is your DN4. DN4 is little bit easier. Why easier? Because here individual signs and symptoms are not having the different kind of scores. Here all of them scores is your 1, yes or no. So symptoms like burning, painful cold, electric shocks, tinglings, pins and needles, numbness, itching. So these are the symptoms. Signs: hyposthesia to touch, hyposthesia to prick, and pain caused by brushing. So these are the signs. And if there is 4 or more, then it is a neuropathic pain. That's why it is known as DN4. So out of these all signs and symptoms, if the 4 symptoms are there or more than 4 symptoms are there, we consider it as a neuropathic pain. Then is your NPQ. NPQ again almost similar. Here there are 12 items, 10 related to the sensations and 2 related to the affect. So these are the the questionnaires have to be asked, but its sensitivity, specificity is not that very great and very rarely used in clinical practice. Then is your ID pain. Here also there are different signs and symptoms, and based on that we can assess what kind of pain it is. Now I am coming to the pain detect tool. Pain detect tool is little more elaborate. In our hospital, as I told, we are using this tool, and many other pain clinics around the world is using this tool. Its sensitivity, specificity is quite high, 85% and 80%. So there are 7 sensory descriptors. What are those 7 sensory descriptors? One is of them is burning. So you have to ask the patient whether there is a burning, tingling or prickling, light touch, is it producing pain? Sudden pain attacks like electric shocks. Is normally we apply hot or cold to relieve the pain, but is it increasing the pain? If there is any numbness, if there is a pain on slight pressure. So all these things we have to assess. Total 7 symptoms are there, and each of them can carry marks from 0 to 5. That means suppose somebody is having the burning sensations. How much burning sensation? If no burning sensation, then 0. Maximum possible is your 5, and it can be in between 0 to 5. Same about all the symptoms. Tingling. How much tingling? No tingling, 0. Maximum tingling sensations one can imagine is 5. Same way, sudden pain attacks, all those things are there. That means out of the 7 symptoms, 7 into 5 is equal to 35 marks will be coming from there. And apart from that, few other items is there, whether the pain is persistent with some fluctuations, whether this the persistent pain with a little slight pain attacks in between them, and another very important thing is whether the radiation is there. If radiation is there, then another 1 mark, only 1 mark for the radiation. So with so these are the different forms available in different languages. It is available. It is easily available in the internet. You can download it and you can incorporate it. You see here, do you suffer from a burning sensations? Never, hardly. So if it will be giving 0, it will be giving 1, it will be 2, 3, 4 or 5 if it is very strongly. In that way, tingling sensations, light touching is producing pain, sudden pain attacks, heat on cold application increasing the pain, suffering from a sensation of numbness or slight pressure is producing pain. So all these things is giving marks. And if there is any pain radiation, it only yes or no. That means if radiation is there, then 1 mark. If no radiation, then your 0 mark. And these are the different patterns of the fluctuations, whether the persistent pain with slight fluctuation or other different patterns of there. So out of all these scores, if the score is your more than 19, then it is definitely neuropathic pain. If the pain is less than 12, then it is nociceptive pain. And if the pain is between 13 to 18, then this kind of pain is your mixed pain. Means here both the nociceptive and the neuropathic component are there. That means there is both neural tissue damage as well as non-neural tissue damage seen commonly in different kinds of cancer pain, and there the pain character or the pain quality is your mixed. So this tool can assess, pain detect tool can assess whether the pain is nociceptive or neuropathic or a mixed kind of pain. So this is about quality. So first we assessed quantity in either unidimensional or multidimensional pain scale. Then we are coming to the quality. Next is your M. Quick questions, make diagnosis. So this is M, make, mnemonic of M. So mode of onset and its location. It helps in finding out the etiology, whether it is sudden or gradual. Say for example, somebody is having the gouty arthritis. Normally it's very suddenly it starts. But somebody is having the osteoarthritis. Patient cannot remember when it has started. It will be very gradual, slow onset. So mode of onset and its location. Then is duration. Quick questions, make diagnosis. So it is D, duration. Duration, chronicity and the frequency. So it helps in a diagnosis how long the patient is suffering, whether 5 years or more than that. What is the chronicity and what is the frequency, whether it is coming daily or whether it is coming 2-3 times in a month, and if it is there, how long it is persisting. So it is duration. Then is your how the pain is related to the posture. Is it affecting the pain? Like some pain is aggravated on sitting, some pains are relieved on sitting, standing, lying down, walking. So what is the relation? Whether the pain is increasing with that posture, whether the pain is relieved on that posture. So these are the posture related. Then is spatial. Quick questions, make diagnosis, pretty simple. So it is S. So like in the cluster headache, trigeminal, very special characters are there. Like in the cluster headache, what will be the description of the patients? Some hot rod is piercing the eye and going towards the occipital. This is a typical description. If somebody is having a trigeminal neuralgia, patient will be telling electric shock like pain. So the typical terms are there for different kinds of pain which can help us to make a particular type of diagnosis. Then is the timing of the pain and diurnal variation. Like in inflammatory pain, what happens? Inflammatory pain more in the morning or after some rest. Otherwise, degenerative pain more on activities. Inflammatory pain normally what happens? It's more in the morning or the afternoon activity, and the more in the morning is more than half an hour. Degenerative pain normally more after some exertion, some activities. Nociceptive and neuropathic. So also we can understand with the diurnal variations, with the help of the diurnal variations. Then is radiation pain. Radiation and referred almost look similar to the patient. The pain is starting from somewhere and going distally. So radiation pain normally, typically, it is described when some nerve is getting entrapped. The pain will be going into that particular areas. But referred pain, normally the less intense, less severe than its original pain. And it is not along some nerves. Like common referred pain is if somebody is having the myocardial infarction and the patient is having pain in the chin, having the pain in the arm. So that is not a radiation pain, that is referred pain. Same way, the referred pain can be there in the facet joint. Somebody suffering from the facet joint having the back pain, and the pain is getting radiated towards the the lateral aspect of the thigh, posterior aspect of the thigh. Like SI joint pain can be referred in the posterior aspect of the thigh, inner aspect of the thigh as well. So these are the different referred area. Radicular pain is a radiating pain. These are referred pain. They look similar, but as a physician, we must be knowing that what is the difference between these two terminology, radiation pain and the referred pain. Then your aggravating and relieving factors. So quick questions, make diagnosis pretty simple. Think really about them. So this is about A, aggravating and relieving factors. So aggravating means whether the movement is increasing the pain, whether some activities is increasing the pain, whether the time is increasing the pain, or relieving factor. Like patient is having very good result with the NSAIDs. So you have to think that it might be the inflammatory pain. Or sitting is completely alleviating the pain. Might be because of the facet, might be because of the canal stenosis. So aggravating and relieving factor gives very important clues to us. Then last one, them, means tied up associated symptoms. As I told that in chip complaint, only 1 to maximum 3 complaints or symptoms will be there. Other symptoms should be noted or listed here. Means tied up associated symptoms, whether the patient is having the weakness, nausea, vomiting, fever, or anything associated symptoms are there. So all those symptoms should be noted. So these are your history of present illness. So you remember in the history, first was chief complaint, next was history of present illness. So history of present illness, we had the 10 points. So these are the 10 points with the mnemonics, quick questions, make diagnosis, pretty simple, think really about them. So these 10 points we have to remember in the history of present illness. Then your treatment history, medical history. This is again very important. Whether there is any history of trauma, whether there is any history of surgery, any other comorbidity. Somebody is having the diabetes, long-standing diabetes. You have to think that the diabetic neuropathy is a possibility. Same way, there are different comorbidities which might be important for assessing this patient, and medicines received, whether that has given good relief or no relief. Like somebody is having a trigeminal neuralgia and somebody has taken the ibuprofen and there is no relief. Definitely it is very important that this pain is most likely to be a neuropathic pain. Whereas somebody is having an inflammatory arthritis, patient has taken the ibuprofen and patient had very good relief. So that also is very important to understand that this might be the inflammatory pain. So the medicine received and whether that has given good relief or not is very important to understand what kind of pain it is. So these all are treatment history, medical history is very, very important. Then is a personal history. How much is the sleep? How is the bowel bladder habit? Whether the patient is having smoking, alcohol. In these situations, the degenerative conditions might be much more seen. Then is your family history. Family history is very, very important. In many conditions, painful conditions, the family history comes positive. Like somebody is having the migraine, somebody is having the rheumatoid arthritis, somebody is having the ankylosing spondylitis. So there are many fibromyalgia. There are many conditions where the incidence is more in the families. So genetic factors are important in these cases. So family history of similar diseases are very important in the assessment. Then is your occupation. What is the occupation? Nowadays, it's very common that somebody is sitting in front of the computer for the whole time, whole day, and having the neck pain, trapezius myofascial pain, or having the back pain, internal disruptions. So these are very, very important, and what kind of job he is doing, or sometimes strenuous lifting can be associated with the prolapsed disc. So the history of occupation, what is the patient's profession, what the patient is doing. So that is also very important in the history taking. Then after all these things, so these are the list, different areas of the history taking. But during the history taking, what we have to remember that whether the patient is having any dangerous signals. If the dangerous signal is there, we have to take immediate action. What is that action? That pain must be assessed by a multidisciplinary team. In that team, not only the pain physicians, there should be a neurosurgeon, there should be a physician. So that kind of, the team should be assessing the patient's pain. And here most of these are so dangerous that we cannot ignore it. Timely management is going to change the outcome. So what are these red flags? One is pain with major trauma. Suppose there is a road traffic accidents. Pain along with the fractures, tumor or infection. So these are important areas. Multidisciplinary team should be there and should be assessing it. If there is sudden unconsciousness with the pain or sudden loss of vision, if there is a motor weakness, progressive sensory deficits, these are also dangerous signals. It has to be assessed. Mild motor weakness or mild numbness is not red flag. So you need not have a multidisciplinary team to assess it. But if it is a major weakness, 3 or more motor power, 3 or less motor power, then it has to be taken as considered as a red flag. If there is a loss of bladder control with the retention and incontinence, overflow incontinence, patient cannot pass the stool, patient cannot pass the urine, is very dangerous. Immediate surgical interventions might be needed in these patients. Sudden onset pain, which is progressing rapidly. So it started last few days back and very, very severe pain. And if the pain is not relieved by any kind of analgesics in few days, 4-5 days, that also can be considered as a red flag. So these red flags, whenever it is there, timely investigations, we need to do the, even the more costly investigations like MRI or other kinds of investigations, a multidisciplinary team, these are needed whenever we are having this kind of the symptoms or signs. So whenever we are evaluating, we have to imagine, you have to think that is there any red flag? If it is there, we have to take proper actions. Then very important part is your psychological assessment. That also is taken by the history. And there are different tools are there. One of the tools which we are using in our hospital is PHQ-9 tool. Then is your Beck depression inventory, Hamilton depression scales. Lot of things are there. The most commonly utilized is your HADS, Hospital Anxiety and Depression Scale, and PHQ-9 tool. These are the two most common tools what are used in the regular pain practice. So this is PHQ-9 tool. In the PHQ-9 tool, you see here, there are lots of questions are there. So these are the questions. Little interest or pleasure in doing things. Then feeling down or depressed. And you see all these points, if it is not at all 0, if it is present for the several days but less than 15 days, then it is 1. If it is more than 15 days but less than a month, not every day, then it is 2. And it is 3 if it is daily. So these are this kind of symptoms, how frequently it is there, depending on there will be scoring. Trouble in falling or staying asleep or more sleep, sleeping too much. Feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself that you are a failure, trouble in concentrating on things such as reading newspapers or watching televisions, moving or speaking so slowly or slow restlessly, both are important, and thoughts that you are better be dead, thoughts of suicide. So these all are having the different points from 0 to 3. When it is 0, no, not in a day, in a month is 0. Less than half of the month, less than 15 days is your 1. More than 15 days but less than 30 days is your 2. And every day is your 3. So now look at if the score is, the maximum score is 27 because there are 9 points, 3 into 9, 27. If the score is between 1 to 4, that indicates minimal or no depression, that this 1 to 4 can be there. If it is 5 to 9, then it is mild depression. If it is 10 to 14, then it is 10 to 14 is your moderate depression. 15 to 19 indicates moderately severe depression. And 20 to 27 is severe depression. So remember, if there is moderately severe or the severe depression, that means if the score is 15 or more, then you must be consulting a psychiatrist as well. You don't treat this patient alone. But if the patient is mild to moderate depression, this patient can be taken care by a pain physician itself. Then this is another scale, Hospital Anxiety and Depression Scale. Here also there are different points and different scores are there, and based on that you can assess. The 0 to 7 indicates the normal, 8 to 10 indicates borderline, and 11 or above indicates abnormal. So this is also another simple tool which can be used in daily practice. This is one history composite areas. So whatever you have discussed here it is there. So normally after the patient's identity, the amount of the pain score, the Unidimensional pain score, then is your pain detect tool, then your different other kinds of history, and this is your PHQ-9. These are the clinical physical findings, and some other scores like fibromyalgia score, AMOR score. So these are all there. Then your images and their investigations. So this is the history sheet what we are using in our hospital, that Daradia Pain Clinic. But similar kind of things you can prepare in your hospital. It is easier because it is very difficult to remember all those points when you are assessing the patient's quality of the pain, when you are assessing the depression. So this kind of tool, history, printed the papers might be very helpful, and even your assistant, the other doctors or even nursing staffs, they also can be trained to fill up these forms. So if these forms are there, so then you can put the ticks, mark the numbers, and finally this patient might be taken to the consultant pain physicians so that your job will be much easier. So when we are taking the history, so these parts can be completed by your assistant or your fellow doctors or nursing staff if they are adequately trained, so that you can save your time when this patient will be coming with the history sheet in your room. By that time, some of the important areas has already been taken care, and you can save your time and make your job simpler. But remember, either you or your assistant or your fellow must be taking the history elaborately. And as we told earlier, a new patient's assessment takes at least 30 minutes. You cannot make a hurry. If you are in hurry, you are going to miss important clues, important points in making the diagnosis of pain. And as I started at the beginning, that this is the most important areas. Okay, one very important area is there, when to refer the patient to an interventional pain physician. When to refer this patient if the patient is being assessed by some general physicians. So when to refer this patient by the pain physicians. When to refer this patient to the surgeon if there is a red flag. And when this patient can be referred to a pain physician if there is no red flag. So what are the red flags? Already I have discussed. If there is no history of any trauma, fracture, if the patient no history of unconsciousness, loss of patience, no severe motor weakness, no loss of bladder. But if the pain is more than mild, if the pain is not relieved by the pharmacological treatment and non-pharmacological modalities, but the patient is also not having any red flags, then that patient should be referred to a pain physician. This message is particularly important for a physician who is a general practitioner or family physicians. So, thank you very much, and thank you for listening. What the areas we have tried to emphasize more is that each steps in the history taking is going to give the maximum information, maximum clues in assessing a patient suffering from pain. So, thank you very much and visit us again.